smiling faces. Let me just, I don't want to see me. I want to see you guys. So, as Kevin said, we're going to start, there we go. I'm going to go, we talked about roughly an hour and 2 hours, but really it's very flexible. So we'll take a break about halfway through. I'm going to try to give like a little 5-minute stretch break too. I find an hour and a half is a long time to sit. But if we get like super into the dual diagnosis and, do a little bit less with the emotional self-care, it's all very flexible. So I want to make sure that we're doing all the stuff that you guys are interested in today. And just like before, once I have the slides up, it's harder for me to see you guys. So, but this is casual enough. Just like, if you're like, hey, I have a question, I'll hear it. And I'll also make sure to check in with you guys like at the breaks and stuff, because I love hearing your input and your experience. And I think that just makes it a lot more fun. And plus I learn too. So I know we don't have Nicole. So it looks like we have Patricia, Megan, Candace, and Andrea. Is that everybody? Am I missing anyone?
Michael.
Oh, and Michael, didn't I say your name? I'm sorry, Michael. I can't see you though, dude. So you're gonna be like the ghostly. There we go. There's Michael. It's like doing a seance. Is Michael there? Okay. All right. So I am gonna go ahead and put the slides up, and we're gonna jump in because I have so much to do and so little time with you guys. And as I mentioned before, hang on. Let me get rid of that. Which one do I want here? Dual diagnosis. I'm going to start with that one. Start the slideshow. Okay. You guys can see the subtitles, can't you? That thing on the bottom?
Yes.
Okay. Did that get rid of it?
Yes.
Yay. All right. So as I talked about last time, my background is mental health, and then I sort of got to know the DD world. So that's a lot of what we're going to talk about today. The truth is, I should just start with this. My experience is that there are very few areas in typical mental health where there's some magically different thing about DD. So it's not like, oh, in bipolar disorder, if you have a developmental disability, you sprout wings. So I think there are a lot of places in which people are looking for some really significant clinical difference in the two populations. I will tell you, and I'm not, my experience is probably like you guys, much more with like kind of garden variety mood disorders and trauma disorders. I don't have a ton of experience with like severe persistent mental illness like schizophrenia. So I can talk about that to some extent, but just to sort of set the stage for what we're going to see in my experience and the reading that I've done, typically what you're talking about is difficulty in assessing what's going on because the developmental disability may make it harder for like a client's self-report on an internal state, or if they struggle with spoken language, it's hard to do that, what have you. And we'll talk about some other complicating factors as well. But I tend to think that not unlike trauma, what we struggle with when we struggle with dual diagnosis are some of the different ways we have to bridge communication barriers or cultural differences in terms of the DD world and the mental health world. Not so much that mental health manifests itself so very differently. Do you know what I mean? So I that's kind of my take on it. You might hear other clinicians who talk about it differently. There are also some resources that you guys are, I'm sure, aware of because you work with NAD. To my knowledge, NAD is really the best thing that I've found out there, at least in this country, in terms of like the MIID and the workbook. But even so, I will tell you guys this: when I started at the government, they didn't quite have enough for me to do, so I read the whole MIID. At that time, it was the first edition, not the second. I just read it all day, which was super exciting. And what I found was sort of a similar thing that usually what we were talking about is there may be differences in presentation, not so much, this is a completely different animal when you're dealing with this mental illness. in someone who's neurotypical or what have you. So, okay, with that, let's go ahead and get started. Oh, here we go. Okay, so as you guys know, my slides are super boring, but please enjoy. Ta-da! So I adapted this training, and we're going to talk a little bit more about some of this stuff as we go through. I adapted this training from a lunchbox series that I did with NAD, actually, for the University of North Carolina. And they specifically wanted to talk about a biopsychosocial spirit model, which I did a lot of in college. And I actually, I think you can, maybe you have to buy the textbook, but I wrote a chapter that ended up being part of an online like appendix for a textbook at the OSU College of Social Work that talked about the biopsychosocial spirit model. This is pretty familiar to mental health folks, so we're not going to spend a lot of time belaboring it. It will provide a little bit of a framework as we talk about various domains. And domain is a social work term that I don't hear very often in DD. So that's kind of fun. But I do want to talk a little bit about the spirit element, because in my experience, both, working and then later supervising, when we talk about the spiritual dimension, often it just means like, does this person go to church? Do they need transport to their church? Check. Yes, no. And that's fine. But I find that often, at least in my neck of the woods with clinical social work, we're sort of scared to go any further than that. And I think that this is something that we can actually really benefit people by talking about. So I will actually address that a little bit later on, but let's jump into some of the concepts here. One of the things that's really important is the bio part of the biopsychosocial. I do find that with people with DD, it's sort of a double-edged sword. In my experience, sometimes people who have a developmental disability, sometimes that's part of a much larger syndrome or congenital, condition that they have. And they may have very medically complex presentations. And there's a good and a bad to that compared to the typical population. The good is that in my experience, you sometimes get people who already have a nurse and a doctor and an NP working with them for lots of like purely medical stuff. And so it's not the same as if you're in a local, let's say, community mental health clinic, and you're like, when was the last time you saw a doctor? And they're like 20 years ago. So in terms of ruling out really obvious things like vitamin deficiency, hormone issues, infection, you guys are probably familiar with this, but if you are working with a population vulnerable to infection, they have limited mobility or they have ports and colostomy bags or whatever, an infection will alter someone's mental state fast, right? Like that's a very exciting altered state. If you've ever worked with someone who's got like a raging kidney infection or something. So I feel like in some cases, DD has an advantage over traditional social work and community mental health in that they may already have really good medical monitoring. Having said that, sorry, I've got a little frog in my throat. I do find that, as we talked about last time, there is a cultural emphasis in the DD world on behavior. And we talked about how that kind of makes sense, right? If you start working with me, and especially if I have communication issues and you don't know what my deal is, and I'm acting in a way that's dangerous or bizarre or freaking people out, my behavior is often a starting point that you immediately want to start shaping or impacting or whatever. And that makes sense to me. The problem is when we kind of stay there. And I do find that the advantage that we in mental health have as we enter into that dual diagnosis world is really bringing that larger perspective of behavior might be where we start, but it can't be where we stop, right? And there's one medical handbook. If I might actually have it somewhere. I can probably find it for you guys. Anyway, they listed 20 different behaviors like flapping or rocking or whatever that actually can indicate an underlying medical or psychiatric problem. So that's a small taste. And when I was researching for the chapter that I wrote years ago, there were dozens and dozens of medical conditions that could create what we would call like a mental health symptom or indicator. So the connection between the body and the psyche, or the body and behavior, is really tight. And I do think that in DD, they tend to sort of lose track of that, right? So if someone's suddenly disoriented, who typically isn't, I think that's the kind of thing that gets people's attention. Like, oh, there may be a medical issue. We need to check for a UTI or whatever. If it's behaviorally focused, that might get ignored. That might get missed as, I don't know, Michael's just being difficult today or whatever. So that, I think, is really worth underlining. We have an advantage when we work with the DD world. We typically have better access to medical evaluation. The behavior might throw people in the DD world off a little bit. So that's one of the things I think we need to pay attention to. The next thing, this is really fascinating. I believe, just in the time that I've been doing this, that this is changing. I think a lot of attitudes have been changing. I think autism has really been sort of a vanguard of helping people embrace a more neurodiverse way of thinking about human beings. But when I first started doing this, was it 15 years ago? It was not uncommon for people to seek out just a general practitioner, much less a psychiatrist, let's say, and be told, oh, I don't work with people with DD. I don't have that expertise. Or they worked with DD patients and did a really bad job. So without going too far into the weeds, there are trainings available for physicians for how to do a clinical interview, with a patient who's dually diagnosed. And I think that is more widespread. I think more doctors have access to that. And interestingly, a friend of mine who teaches at the OSU College of Medicine is spearheading research for increasing the exposure of doctors in medical school to a wider variety of patients, including people on the autism spectrum or people with a developmental disability. All of this is to say, I think our jobs are a little easier now than they were before, but we still have to pay attention. If we're working with a provider or a family and they're sending, their individual to a doctor or a psychiatrist, does this person have any kind of experience or training working with this patient population? So I think that's something that we can really be advocates for, and we need to pay attention to it. I know sometimes, especially with psychiatry, you're so excited to get someone in the door somewhere that it's kind of like, oh, I'll take whatever I get. But I do think that's worth a conversation. Okay, so moving along. Some of this stuff I think we've already talked about, just about the incidence of DD and mental illness. And I will say that here again, up until recently, I think DD had a little bit of a leg up over mental health, in that I think providers in the DD world, I think, had a better idea of how many of their folks also struggled with mental illness. And in the mental health world, I don't think we were quite as savvy about it. At least speaking for myself. And I also think that there are lots of people who sort of fall into that gap where they're high functioning enough that they may not qualify for DD supports, or they have minimal DD supports, but they have some of the worst outcomes that we get, right? Especially in that community mental health world. So I feel like this is where mental health, we talked last time about DD is kind of catching up to us in terms of like trauma expertise. Where I think we're catching up a little bit is, some of the people we struggle with the most, who struggle with addiction, corrections, they're just hard to serve. Probably a significant portion of them are at least in that borderline intellectual functioning range. Some stuff here, we don't have to spend a lot of time on it. We used to think way back in the day that there was sort of this myth that if you had a developmental disability, you couldn't also be mentally ill. I don't know where that would have come from, but that was like decades ago. And now I just don't encounter that so much anymore. I think most, at least physicians and psychiatrists don't think that, which is good. We know, in fact, that having any kind of developmental disability puts you at a significantly higher risk of having any kind of emotional or in this case, I'll lump in behavioral disturbance. So there we go. Okay, we've already talked about some of this. Here are the challenges in diagnosis. I think communication issues are probably the primary thing. And again, what I found as a practicing psychotherapist, getting into the DD world, one of the things that astonished me was how much data we have available when we are working with someone who has, let's say, moderate to really comprehensive supports, right? So if you're working with someone who's in a group home or they're in a residential center, whatever it is, they have so much more staffing often than a lot of the people on a community mental health caseload, especially adults. Kids, you tend to have more, right? A kid is more likely to be in like residential treatment or something. But once you get into that adult population, we often have no idea what's going on in that person's life between appointments. Whereas with DD, you're more likely to have staff and family members and SSAs and behavior specialists all over the place. So I would say that we need to be mindful that if I'm talking to Candace in an interview, I might have to figure out like how do I communicate if Candace has limited verbal ability or what does that look like with her? But I have this gold mine of people around her often who are taking notes all day long because they've got to log stuff, and who in the best case scenarios have known Candace for a long, long time. So they may be able to discern subtle changes in affect or presentation. They may be the ones to help really do a lot of problem solving about, hey, we tried this, it doesn't seem to be making any difference, let's tweak that. So that's, again, where I think the differences in the DD world can really be to our advantage. And I also think that there have been a lot of advances in communication technology. So as mental health folks, it's important that we be familiar with what's some of the technology that folks may be using for communication. Complex medical presentations, again, just to highlight that one last time, you really, for me, if I'm working with someone where I'm not sure about the diagnosis or I'm struggling to figure out an appropriate like treatment plan, I really want to make sure that we have absolutely up-to-date comprehensive medical assessments going on and people really looking at the whole board of what might be going on with this person. Diagnostic overshadowing. I can't remember. Did we talk about that last time? We did. Okay, good. Yeah. So again, I like to remember that this cuts both ways, right? So going back to Michael, I might attribute everything that's going on with Michael to his developmental disability and fail to identify either a mental health diagnosis or a medical issue, and the opposite, right? I might, be frustrated with, for example, I never use the word resistant. That's a whole different conversation, but as a clinical supervisor, I will not engage with that word. But I will say it's easy to look at Michael and go, oh, he just doesn't want to be a part of the session today, and not look at, I'm expecting Michael to sit through a 60-minute verbal, sedentary talk therapy session, and that is not going to get it for that dude. But play therapy or sand tray work or, whatever might be a lot more suitable for him. So we really just want to think of diagnostic overshadowing as a river that flows in both directions. And of course, as you're seeing, just like you guys, I think already are very clear about, it really what this means is that everything has to be very, very individual, right? So I simply am not going to be able to do therapy with Megan the same way that I do with Michael, the same way that I do with Patricia. It just isn't gonna, that's not how we do good therapy with neurotypical folks. And we have to keep that even more front and center, I think, when we're dealing with dual diagnosis. Challenges in interviewing. Based on the time, I'm not going to get into this, but there are some really good presentations out there. Dr. Julie Gentili did some, largely through NAD, but there's some other organizations years back. I'm sure it's still out there, where she talked in more detail, more for medical audience, about how to do interviewing, right? So things like being aware that if I'll pick someone else, if I'm talking to Candace and I give Candace a list of things, like, Candace, have you been feeling happy, sad, scared, mad? I don't know, whatever. Candace might be most likely to endorse the last word I said. So I might need to present that to Candace again later, switching the order. And that's more likely to, kind of adjust for that. Making sure that I'm very clear about how, as a friend of mine likes to say, just because you have a developmental disability doesn't mean you're dumb, right? So people with developmental disabilities, especially with a trauma history, can be very, very savvy about compliance, right? And being a compliant patient or a compliant client. So really working on that rapport and finding lots of different ways to ask the same thing, again, to try to adjust for Candace, trying to say what I want to hear. So those are some examples of that. And again, I think what's really beneficial is when we have family members or favorite staff or people who really know this person, sometimes we may have them in the interview, which is a little weird. Unless you've worked with young children, you may not be familiar with that. And speaking just for myself, it can feel a little funky to bring a lot of people into a process that I'm used to being very, very private. But that can also be helpful, so that somebody either in the moment can help with, Candace, it's okay. Remember we talked about the other night when you were crying? It's okay to tell Lara about that. So they can sort of advocate in the moment, or they may be able, like after the interview, sometimes to go, Candace didn't really endorse this when you mentioned it, but she was talking the other day about wanting to die, blah, blah, blah. So again, for me, that's a little bit of a cultural shift in how I'm used to working, but really using that resource of the people around the individual, I think that can also be helpful in terms of overcoming some of those interview challenges in my experience. Some assessment tools need to be modified. Yep. Again, I think that NAD is a good resource for that. I'm sure there are other things out there. I don't know if you guys also do anything with AAIDD. I don't know, it's a million letters. It's American Association of Intellectual and Developmental Disabilities. Now, they tend to be more, this is just my take on it, right? So take this, for what it's worth. I find that NAD tends to be a little more focused in the boots on the ground, direct service professionals, that kind of approach. AAIDD is slightly more geared for like psychologists, behavior analysts, tend to be a little bit more academic, but there's a lot of crossover and they're really good people. And a lot of people are in both, actually, if you look at board members or speakers at conferences. But AAIDD also is a good resource. And they may have some assessment tools. I haven't looked at them lately. If you asked me on a gut level, how would you modify an assessment tool? Skipping the validation process and all of that. I think it's fairly common sense. Does it need to be broken down into smaller pieces? Do you need to account for, you need to do this a couple of times to try to get past, compliance issues, that kind of thing. So I don't want us to wait until something's been absolutely gold standard stamped before we're willing to try to adapt things. But I also think it's important to look for tools that have really been, checked for validity and all of that stuff. So it's all really emerging. There's so much more now, even than there was 15 years ago. So I'm encouraged about that. And we'll talk about that a little bit more later when we get to treatment modalities. So let's see, placating or pleasing interview we talked about. Confusing interview questions. Again, now I'm the worst at this. I tend to load a question when I'm asking it. And honestly, I'm going to blame Cleveland for this because my brain works really fast and I talk really fast. And here in Columbus, that does not always go great. So, for example, if I'm talking to Patricia in a session, a bad habit of mine is I might be like, so did that make you feel this way? Or maybe it made you feel another way. Or, I'm wondering if perhaps you thought about it in this way. which is a bad therapy habit anyway. But again, for people with a developmental disability, you really want to think about simplifying the question, asking one question at a time. And again, finding a way to circle back around to it a bit later, just to try to build a little bit of that internal validity in the interview or in the session. Okay. Yes. Last thing. So it's important to remember, this is going to sound weird, but a developmental disability impacts development. And so, for example, in some individuals, let's say in their late 20s or early 30s, we may see behavior that we, working with the typical population, would expect to see more in early adolescence, like jokes about boobies, stuff like that. And rather than seeing that as a symptom, it's important that we keep in mind that that might be developmentally appropriate behavior for where they are. And again, really what this boils down to is knowing the person. You just can't use a one size fits all with this because of things like differences in developmental stages. Okay, I'm keeping an eye on the time. So you guys, here we go. Woo! Some more graphics. This is a presentation, as I said, that I developed initially for people more in the DD world. And so it was to introduce them to what the DSM looks like. You guys know this, so I'm not going to spend a ton of time here. Yeah, I don't think I'm going to spend any time, actually. So we can just enjoy the graphics and move on. And if we need to come back and talk about any of this, we can. Whoa, there we go. Yeah, I will say this. We talked about borderline personality disorder a little bit, I think, when we talked about trauma. I do find it's a little bit of a joke, but it's a dark joke that someone who's been diagnosed borderline is the person who's really made everybody super pissed off. So I will just say this, that when you look, like there's some disorders, let's say schizophrenia, again, you might be dealing with difficulties in communication. So if someone has low speech or little or no speech, obviously it's much harder to figure out if they're attending to internal stimuli than if they can just tell you. But I will say that the fuzzier a disorder, the fuzzier a diagnostic category is, the more I think bias creeps into it. So for example, let's talk about borderline for a second. My favorite, your favorite, everybody's favorite. What is it that tends to raise flags for a borderline diagnosis? Well, the big one is manipulation, right? That's when everyone's like, Laura's so manipulative. She's definitely borderline. Well, okay, fair enough. But ask yourself, what is manipulation, right? The literal meaning of the word means using my hands to change something. So what do human beings do? Along with other species, which is fun, we literally manipulate our environment to be more suitable to us. We build houses and make clothing and stuff like that. If you were as overwhelmed and confused and powerless as many of our individuals find themselves, would you not start manipulating your environment as much as you possibly could to make it work for you? Sure, you would. Right? So right there, I feel like we really need to be vigilant about what exactly are we talking about when we talk about this individual having borderline personality disorder. I personally would love to see borderline reimagined as sort of a double axial diagnosis that identifies emotional instability or emotional, I'll just leave it at that, emotional instability and unstable sense of self. I think that is a much more accurate way to talk about it. And it's not hard to imagine, especially when we add the conversation we had last time about trauma. If we're talking about poorness of fit with a caregiver, someone who is not anticipating or equipped to deal with an infant with special needs or a disability, anything where the caregiver was multi-stressed. So imagine somebody with like fetal alcohol syndrome and an addicted caregiver. Right there, you're laying the groundwork for an unstable sense of self, at least an insecure attachment, right? So I prefer I would rather, if I were working with Megan, I'd rather skip the borderline diagnosis entirely. And I'd rather that you talk to me about, yeah, her emotions are really volatile and unstable. And she seems to have a really unstable sense of self. So she's constantly trying to figure out how to make herself feel safe. But the thing that makes her feel safe, favoritism, closeness, whatever, also floods her. So we see that push pull of borderline. I love you, I hate you, right? When we can break borderline down into its components, number one, I think we get a much more compassionate view, but also we get a more accurate view. And so I don't encounter this all the time, but when we're talking, let's say if we're working with a provider or whatever, and they want to talk about, they want to do a case consultation, they're like, oh, Michael, blah, borderline. I really try to use that as an opportunity to break that diagnosis down for people a little bit and start to say, let's talk about how Michael experiences his self. Does he feel like he exists when everybody leaves the room? You know, that kind of thing. And let's talk about how Michael tolerates distress. So if an emotion is distressing, does he immediately start headbanging or cutting himself or, you know, falsely accusing staff? Okay. And obviously we can also talk about the problems that creates, because those are real problems. But I find that if you are working with a family or a staff, whatever, sometimes if that stigma has come along with the diagnosis, I prefer to break it down. So that's my commercial about changing borderline personality diagnosis. Let's move ahead here. Okay. So again, this is just good old-fashioned biopsychosocial. None of this is terribly unfamiliar to you, but this is sort of how I broke it down for a DD audience. These are things that, again, depending on the services surrounding this person, you may find that people are very keyed into this. So they can give you information right away about how they're eating. And a lot of folks with DD, as I'm sure you know, may have conditions that affect how they eat. So they may, you know, they may be choking hazards, or they may, if they're on the autism spectrum, they have a lot of food rigidity or texture issues or la la la. So you want to make sure that you're including those and you're looking at the baseline for this person. Sleep disturbances, again, keep in mind that a lot of our folks have various neurological damage, which can affect sleep cycles. But I'd also want to know, you know, let me pick Patricia. Does Patricia not want to sleep in her room and she fights to sleep on the couch in the staff office? Well, maybe we're not talking about a sleep disturbance. Maybe we're talking about being triggered by trauma, right? Sexual dysfunction. Okay, this is super fun. One of the things the other side of that benefit that I talked about, that you often have family members or parents that are very closely involved with this individual, and can give you lots of information about this person, or staff people who are very close to the individual. One of the biggest issues I often find is we really don't like dealing with the sexuality of the people we serve. We don't care for it, especially parents. If they're used to seeing their angelic, let's say Down syndrome kid who's now an adult and who is now masturbating or talking about wanting to have sex or finding ways to look at porn or whatever, or is identifying as LGBTQ or anything like that, we may find that parents really struggle with that because you know, they're used to being very protective and they're used to thinking about the limitations of their child in some ways. And the idea that their child is sexually maturing can, to use the clinical language with you guys, freak them the F out. Like, people freak out sometimes. So your ability to come in and talk in a very normalizing way about masturbation's really normal. We may have to talk about not doing it in the common room, right? Like, that might be a conversation. Or, you know, Michael's saying that he wants a girlfriend and he wants to have sex with a girlfriend is really okay. And this is off into a whole nother training now about how do we support relationships and how do we help people with DD go on dates and stuff like that. That's a whole different conversation, but there's some great people out there. We recently lost Dave Heilsberger, who is a giant in this area and who did a lot around the benefit of adult relationships for people with DD. And one of the things I heard him say in a training was, we have all these targets for people. We want to address this behavior. We want to increase this social skill, or we want to get them, using the bus on their own or whatever. And those are all great. But he said, whenever I sit down with somebody with a developmental disability and I ask them what their goals are for themselves, they say the same three things. I want a job, I want an apartment, and I want a romantic partner. Same thing all the time. They don't identify, wow, it's really important to me that I learn how to use the bus. So that's not to diminish the goals that we're thinking about. It's simply to say we really need to remember the necessity sometimes of bringing that into the conversation, especially if people are feeling freaked out or weirded out about it. And there's some research that Dave cited the last time I saw him speak, where he said that being in a close, loving adult relationship actually improved how people performed on IQ and support inventories, which is incredible. And we know that from the mental health world. That's, again, where I think we bring our expertise to the table to say, we know human beings in general do better when they have naturally occurring, organic, not paid, close, loving relationships with human beings. And if that's an adult, romantic, sexual relationship, great. If it's there are other wonderful relationships that can also benefit people, but human beings need to be close to other human beings, and most human beings need to be sexual too, right? Obviously there's a spectrum to that too, but you guys get it. Okay, chronic unexplained pain. That's another good example of, I would be if somebody's doing something that is new from their baseline, especially if it included something like head banging, stuff like that. We know that sometimes people do that to address pain. So like, I think allergies are worse in Columbus than Cleveland because we don't have the lake, but my allergies have been atrocious and I've had tons of migraines. If I didn't have a way to tell someone that was what going on and that I needed a Tylenol or whatever, I might start banging my head just to try to relieve the pressure. So making sure, again, that we're always working closely with our medical team to make sure there's not a physiological issue. Okay, moving on. Memory lapses, difficulty making decisions, decreased ability to concentrate. With these here, again, we're really talking about the necessity of an individual baseline. It's very important, and it will probably take some time. I'll just throw this in. This is not a one intake kind of conversation typically, to identify what is the baseline for that person so that I can see changes. Because what I might think is a lot of difficulty making a decision, if someone's on the autism spectrum and they're having sensory overload, that might be what I'm seeing, and that might be very typical for them and not an indicator of depression the way it might be in someone who's not neurodiverse. So paying attention to that. Restlessness, agitation. Restlessness can also be an indicator for pain. The less somebody can speak, the more they will show you with their body. So pay attention. When somebody's suddenly pacing and doing all that stuff, it might be that they're experiencing increased heart rate. We also, the quick little commercial here, we aren't really going to address grief very much in this training, but I will say that we do see a behavior that I call wandering when someone is experiencing grief. And grief is significantly statistically associated with emergency psych admissions for people with DD. They've had a significant loss within 6 months of the admission, and grief tends to be overlooked by staff. So you may be meeting with a client, they're agitated, they're restless, they're combative, they're whatever, and you ask what's been going on. Be aware that staff and family might be inclined to forget to tell you, oh, their favorite staff person left 2 months ago, or, oh, their roommate died 4 months ago. We think that grief doesn't impact people with a developmental disability, and that is incorrect. It may have a bigger impact, actually. So this is an older study now, but there was a study done that said 50% of patients admitted for an emergency psych admission had a significant loss. And that staff were, I think there's only 17% of the time staff mentioned it spontaneously in the intake. So be aware of that. Again, you guys kind of get it here. Let's take fearfulness, for example, or feeling out of control. Again, it's really important that we try to relate with the situational stressors in that person's life. If I lived the life that a lot of our clients live, I would feel very out of control sometimes because I am often out of control, literally, of what's happening around me. I may not be in control of where I live. I'm not in control of who I live with. Imagine that somebody just said, oh, okay, Candace, you're going to have a roommate now, and we're going to randomly select them. And they may have literally nothing in common with you, but you guys are going to share a bedroom. Right? Like, it's easy to lose track of, at least for myself, how little control some folks actually have. So keep in mind that that may not be indicative of a symptom. That may be an absolutely reasonable reaction to their situation. Okay, la la la. I think we can keep going. This stuff, oh, we've talked about before. Non-compliance. Oh my God, you guys, I'm so non-compliant all the time. But I have the resources and advantages that allow me to be non-compliant in usually a pro-social way, typically picking fights on Facebook. But or failing to do stuff I'm supposed to do. If I don't have that, then it's going to look very different, right? Remember how many ways in which an individual with a developmental disability, especially with moderate to extensive support needs, how many other people's expectations they have to meet throughout the day, right? It's a lot. So really think about it when staff are telling you someone's non-compliant. What does that mean? And again, we're typically looking for baseline change as well. Anytime you see a disintegration of previous skill, I'm very interested in that. And again, for this population, they are also vulnerable to things like infection. So if I can typically speak and now suddenly I'm not speaking, that's really important to pay attention to. La 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 la. The last baseline exaggeration. I can't really remember what that means, so we're going to skip that one. Maybe I'll think of it. And this last one's really important. Recurrence of institutional behavior. We know, not unlike people who've been in the mental health system, if we had institutions anymore, if you have someone who's in a hospital for 30 years and then you transition them out to a smaller group home or an apartment in the community, then they have deeply ingrained, I don't like calling it behavior, I'm going to say skills, survival skills, like hoarding, stealing, aggression, whatever, that allowed them to survive in that institutional environment. And now it doesn't fit. Or now it's more easily visible because they're hoarding food under their bed in the group home and everyone's upset. So number one, if you're working with someone who's making that initial transition, that takes a ton of time. And just like every other human being, when they are under stress, they go back to what worked the last time. Sometimes when I'm talking with direct service professionals or family members, if they're having trouble relating to this or if they're freaked out about the behavior, sometimes I liken it to like when a toddler suddenly has a new baby come into the house, what does the toddler often do? Well, they need a bottle again. Suddenly they're having accidents. Suddenly they want their blankie or, whatever. And as we know that this is just, oh my God, the world is upside down and I don't know what to do with it. And I'm going to go back to what I know works. And maybe it's going to get me a little bit of extra nurturing in the bargain. Great. And of course, the way you deal with that is not by shaming or punishing, but you give them the extra support. You treat them with a little extra TLC. And I try to identify if there's a stressor that's causing this. So for example, if my family ditches me every Christmas and I sit at home by myself because they don't show up, you can pretty much expect that once we start heading towards the holidays, you may see a regression in my behavior. So helping teams understand this, helping them approach it from a holistic standpoint and not a merely behavioral or punitive standpoint. And a little side note here, in my experience, it is the more you're dealing with somebody who uses their body to show us what's going on, or who expresses things behaviorally, the more we tend to punish or want to punish what we call attention seeking. And again, this is where I think our mental health background can be very, very helpful, because you guys know, and I know, what do human beings need only a tiny bit less than food and water? Attention. Connection. That our brains literally develop in the womb to connect to other human beings long before the part of the brain that can do math and write essays and stuff. So for the human brain, the connection is far more important to life function. So whenever staff say, ugh, Patricia's just being attention seeking, the first thing I always do is go, you know who else loves attention? This gal. Like, literally, look at what I do for a living. So I try to bring that context in of, when you have pro-social and adaptive ways of getting what you need, then we don't call it attention seeking. We call it being a people person. When you're driving everyone crazy, we call it attention seeking. And from a behavior standpoint, sometimes people will say, well, if we give Patricia the attention she wants, isn't that reinforcing the behavior? And my response ranges on a short spectrum from, yeah, maybe I don't care, which is not usually what I really say, to something a little more thoughtful, which is, sure, if we only pay attention to Patricia when she's doing the annoying stuff, and we never pay attention to Patricia when she's doing the stuff we want her to do, then yeah, sure, we're shaping that behavior to get the less desirable stuff more frequently. But if we approach it from a more holistic human perspective and we say, Patricia seems to be struggling, what can we do to help Patricia feel safe and loved and comforted? I think that's just better for human beings generally. And again, ask yourself, how often, this was a point that John, oh, his name just went out of my head. It'll come back in a second. The gentle teaching that John something did, that I'll tell you guys in a second. He talked about what we do on our hard days. So when you have a hard day and you're stressed and something didn't go right and you got into an argument, not where you guys were, because you guys, I'm sure there's never any bad days where you guys are, but when you have a tough day, imagine that someone said to you, hey, you know the thing that makes you feel better? Like hanging out with this person that you love, or doing something fun, or having that extra cookie, or whatever it is, the thing you do to make yourself feel better. You're not allowed to have it until you demonstrate that you've earned it by changing your behavior on this tough day. It's a simple paradigm, but most of us don't live that way. If you come home from a tough day and you have a partner or a family member, whatever, and you're like, oh my God, you know what? I'm not gonna do the yard work, and I'm not gonna do the laundry, and I've just had a really crappy day, and I just need you to hug me, and then I want to drink wine and watch Law and Order reruns. You would get that. You would have it. Or if you said, I'm going to stop at Starbucks and get that frappa mochaccino because this has been a terrible day, no one's telling you you can't have it, or that you need to do your tax returns before you're allowed to have it. But in DD, we make people demonstrate that they don't need it. In other words, they start acting the way we want them to before we give them the thing. Pretty backwards. So again, my point here is not, John McGee, that's who it is. Thank you. The point here is not, lavishly reward people for doing things we don't want them to do. It is, again, I think, a bit of an advertisement for, we in mental health have that holistic view often, and we can bring that, especially when a team is stressed and burned out. If an individual is very challenging, I understand how they get where they get. We certainly see that in mental health too. But being able to say, maybe Patricia needs a little extra TLC on those days, not less. And maybe we find ways. What I like to do is, when someone is struggling and we call their behavior attention seeking, how about if we give them the attention before the behavior, right? So really quick, when I worked with teenagers, also the group of people that are likely to make people really angry at them, there was a kid who I was in a partial day program where they would have a classroom day but they would also come into my office for sessions and things throughout the day. And, I had toys and things to fool around with in my office. And this one kid struggled in class, often felt overwhelmed, whatever, and would act up to then get sent to my office. And the teacher, understandably, complained and said, he just does this to have one-on-one attention with you. And I was like, yeah, probably. So what we did, instead of withholding it, which I think is the reflex a lot of people have, is we said, how about if we give you more and you don't have to ask for it by behaving like a jerk? So we agreed that I think it was like the last 5 minutes of every hour, he would come to my office and just chill out and, play with the sandbox or whatever, in addition to regular sessions. And he would have that 5 minutes or 10 minutes, whatever it was, whether he'd had a good hour or a bad hour, it didn't matter. He didn't have to ask for it. It was scheduled and we would do it. And sometimes it helped because he was having a really crappy day. Sometimes it didn't really seem so necessary, but he had it and he didn't have to wonder when it was coming next. And what happened over time, it took a few weeks, but what we started to see, there was one day when he was like, gosh, Laura, I'm really sorry. I'd love to come hang out with you because I know how much you look forward to it, but I'm going to have lunch with some friends I made instead. And I was like, whatever, fine, I guess. So that's a small example. I'm not at all implying that it's always so simple, but I do think that mindset gets us further down the road. And this is something that a lot of us in the mental health world, I think, are kind of already attuned to. And so that's what I think is really helpful to bring to that. Okay, I'm mindful of the time. So we're going to skip ahead a little bit. Oh, yeah. All right, so I just chose a couple of examples here, but there is an increasing amount of literature, and this is really new. I would say within the past 5 years, I've seen a lot more research out there in terms of, is therapy effective for people with developmental disabilities? And if you're interested, the New York Times just published an article today about, does therapy help anybody? And the answer is yes. Most of the time, sometimes not, but usually yes, but we're not really sure why. Anyway, that's been a conversation for 100 years. What we know about psychotherapy and DD is that yes, it helps. And again, I talked about this a little bit with trauma as well. The skills that make us, for those of you who do clinical work, or if you're, partnering with people who do clinical work, the things that make you a good clinician should set you up for success for working with people with DD, because it is all about tailoring and meeting people where they are, which we should be doing anyway. Now, when someone is, pretty different than our typical client, we are going to need those guides. So we need the family members, we need the staff. And again, just like in a clinical interview, it might feel a little weird, but having a family member or a staff person in a session could be the way to go. Doing common sense adaptations, like, I can't imagine a lot of people with a developmental disability who can sit for a 50 or 60-minute therapeutic hour, but 20 or 30 minutes, yeah, they could do that. Should we be outside walking instead of sitting in chairs? Maybe. And honestly, a lot of neurotypical clients do better with that too. So I don't, again, want to simplify it. Sometimes it takes a lot of thought and a lot of trial and error. Not everybody's super easy, but I do think that, once again, our training and background in mental health actually sets us up to do that. And here, you guys might be ambassadors with other mental health providers to really give that message. So I gave you guys just a couple of examples of studies that had been done specifically. EMDR, there are a number of DBT programs that have been developed for people with DD that have been quite successful, group therapy. So it's out there. And I expect that we're going to see more and more studies that confirm that with adaptations, there's no major statistical difference in outcomes in terms of success for these therapies. Also, as would be sort of common sense, a lot of therapies that aren't verbally focused seem to be especially well suited. So sand tray work, play therapy, art therapy, music therapy, EMDR, stuff like that can work really well with that population. And interestingly, if any of you are going to be at the NAD conference in Ohio in July, I think. I'm going to be presenting with an amazing woman from Cleveland, the amazing Kenya Wood, who is a dance. She's a dancer and a choreographer and a teacher, and she has done some dance therapy stuff with different populations and will be presenting specifically on dance and movement and trauma for people with DD. So I love doing that session. I hope you guys will join us if you're going to be at the conference. But I would look to see more and more literature that continues to confirm this. Done sensitively, therapy can be just as effective. I think I was going to say more about that, but I'll come back to it.
Just a question, is the cognitive CBT trauma focused therapy?
Yeah, I did not see one for those in particular. And I will say this. This is now really about clinical preference here. So I'm not at all saying this is how you have to think about it. Generally speaking, because I'm not a CBT therapist, I typically don't anecdotally, and some people like Vanderkolk have talked about this, that trauma focused CBT seems to be effective for I would say like single event trauma and maybe traumas that have happened where there's you don't have that triad of early, severe, and chronic. When we're talking about early, severe, chronic trauma, trauma focused CBT, I think, can be a helpful adjunct, but you're probably going to need to get deeper into the brain and body. So movement therapy, some of the expressive therapies, somatic experiencing or EMDR, may be where you're heading with that. So I know I'm answering way more than you asked me. This is what I would think. If you're going to do CBT with a client, and if they're high functioning, I think you can, then you could certainly do trauma focused CBT with that same client. And you might think about adding trauma focused CBT to other forms of trauma therapy when you're working with trauma that maybe is a little deeper in the body, right? And what the caveat then that I would put in there is that if an individual has a developmental disability, you may already be looking at shifting away from the cognitive and more to the brain body movement oriented stuff, simply because the self-report of CBT might be harder. Does that make sense?
Yeah, and I think that some of our therapists have done the trauma scrapbook with people.
Oh God, I love that. Yeah.
Yeah.
Yeah. And as you guys know, anything multisensory is also really helpful. So if you really asked me to weigh in on this, I think what it would boil down for me is this. Now I feel trust with you guys because you're my mental health fam and you're in Cleveland. And so I'm just going to say this, I'm going to totally nerd out, but I feel like this is a safe space. Okay. The wand chooses the wizard, right? The thing that I think that I would talk to my grad students about was we can look at modalities for their effectiveness, but we also choose the modalities that fit best for us. What you are most comfortable with as a clinician, where you feel like it aligns the best with your temperament and your mind, is often the kind of therapy you're going to do, right? So to get to your point, can trauma-focused CBT be effective with an individual with DD? Sure, if it's the right person and if it's the right clinician. So if CBT is your jam and you feel comfortable and you feel grounded and present, then you're probably going to be more successful even with that DD client than I would be doing CBT, because it's not my thing. I have a different modality, right? So I would say that with DD clients, you need to be maybe a little more sensitive to how well the modality fits them. With a neurotypical client, the truth is they could walk in a room and a therapist who uses CBT or DBT or, oh God, internal family systems or psychodynamic, whatever. There's a much larger range that if you come to see me and you think I like you and that we're in it together and there's a good therapeutic rapport, chances are you could be successful with me using a wide variety of modalities, right? We know that. With DD, you're going to have to pay attention a little more closely to client fit for the modality. But ultimately, I still think it comes down to that relationship. And so, if you are awesome with trauma-focused CBT and you're awesome at building relationships with clients and you're intuitive about how to make it fit for them, I think you're going to find that it can be just as successful.
Yeah,
So,
I think Times, Laura, that they did the New York Times study I think they did talk about relationship,
Hmm.
that too. So, I mean, that's always been a huge one.
Yes. Yes, absolutely. In fact, there was a book that came out a few years ago that did a huge meta analysis over 100 years of data and said that again, you have to pay attention to client fit. I'm not going to do Jungian analysis with someone with schizophrenia, but generally speaking, it's about the rapport. That is when clients seem to relate. The clients report the highest rates of success, even if there's not huge behavior change, which is interesting, right? Part of why therapy helps is because we feel like it helps because we're sitting in a room for an hour with someone who cares about us. Yay, right? So, again, I'm so excited to talk to you guys about this because you have that expertise and you may be the people who help bring other therapists in. This is what I was going to say before that I forgot. One of the hidden benefits to working with the DD population. I was working with a rural county that had to, by necessity, had to do a lot of really close collaborating with the local DD board because nobody had enough resources, right? So what they came up with was the local DD board said to, I think the local ADAM board, whatever, who is the primary provider in the area, they said, look, if we give you a room and 2 comfy chairs and clients that we promise will have 100% attendance rate, will you send a clinician out to us once a week? And they were like, yeah, because as you know, what is the constant battle we're fighting in mental health? Billable hours, right? If people are, especially if they're Medicaid providers or whatever, productivity, if you can work it out, if you know, one of the ways that I think you can make it attractive to other mental health providers, if that's something that you're working on or coalition building or whatever, is hey, with a little bit of planning, those people will show up for that session, right? As opposed to the other, I think industry wide, the no-show rate tends to be around 30%. So if you can increase productivity by 30%, that's pretty attractive. Okay, so keep in mind the social dimensions. Again, this I sort of touched on this before, that it's you want to make sure not to look at something as symptomatic when really what you're seeing is a social issue, right? So biopsycho, now we're at social. Communication we've talked about a lot. The toll of social isolation, I think, gets we underestimate it in many ways in this field. And so I think that's something that we constantly have to be looking at, whether that's romantic relationships, sexual relationships, friend relationships, that is a constant issue and directly impactful on mental health, as we know. The last thing I'll talk about here is that we're used to working on like social skills with some folks, especially people like on the autism spectrum. It's helpful to remember that when we're asking them to, have a conversation, try out this new skill we're learning, how big a risk we're asking them to take. And again, as you guys know, that is completely developmentally appropriate to be freaked out about friendships or to feel like the social stakes are really, really high if we're perceived as gawky or weird or whatever. So again, I think that's just a sensibility that we can bring that can sometimes get a little bit lost in the shuffle in the DD world. Okay, grief, I've already sort of talked about this, but grief can impact all the stuff we've talked about. And I hope grief will be sort of the next big thing in the dual diagnosis world that we pay attention to. I think there's still plenty that we need to do with trauma, but I think grief is sort of the next part of that. But just for time, I'm going to move on. Jumping to spirituality. I don't know how you guys feel about this, so I'd love to hear more. And do I have anybody who's got chaplain training in the room? Am I making that up? I thought, Michael, that might be you. I think I'm making that up. Okay.
No, that was Kevin.
Okay. So I think that, oh, that's right. You guys are, that's why I think that. I have found, and I talked about this when I taught grad school a lot, I have found that in mental health, we can meet somebody and, the sitting down with them for the first time, be like, oh, do you have any childhood sexual abuse? I personally don't start that way, but you know what I mean? Like we can, when we're doing an intake, we can ask about extraordinarily personal things. But talking about spirituality, we're like, ooh, oh, ooh. And I think there's we're going to talk for a few minutes and then take a break because I know you guys have been sitting for a long time. I think there's a taboo there and there's a reason, right? We do need to be mindful. We do need to be respectful. It's an important boundary, I think, professionally. At least speaking for mental health and social work, and I'm sure it's the same for psychology or whatever, that you never, 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 never want to be perceived as proselytizing or, bugging somebody about why your religion is what they should be doing, all of that. But I think that constraint has led to a somewhat under-identified element to being a person, and that is spirituality. So I want to take spirituality out of the realm of religion for a minute, which I think can help us feel a little bit more comfortable. This is not about having a theological discussion with somebody. This is not about talking about, well, here's why you should be a Hindu. Many human beings experience their spiritual life through a religion. And if you talk with somebody where that's a robust part of their life, then maybe what you're doing is simply making sure that gets supported. So if I move to a new group home across town, make sure that I can still go back to my church. And I think you guys are sensitive to this already, but just because I'm Presbyterian doesn't mean I can go to the Presbyterian church down the street. And that's the same thing as the church I grew up in. So really making sure that we try to support whatever religious or spiritual life is already there is extremely important. But I do think we can engage people about this dimension of humanity that, not unlike romance and sex, tends to get sort of pushed to the side when people have a disability. I think we aren't comfortable with it, number one. And number two, I think it's easy to go, well, if Michael has a lot of disabilities and needs a lot of support, he probably doesn't even experience this or think about this. And that may not be true at all. So when we talk about spirituality, there are different ways to approach it, but I think we can break it down into some big elements of what spirituality might be thought of. Okay. So one is connection. Some of this relates to the work of Viktor Frankl. Have you guys read Frankl, Man's Search for Meaning? If you haven't, my grad students read it. It is, let me say this, it's not a fun read. Frankl was a psychoanalyst in Vienna who he and his family were sent to concentration camps in World War II. He was the only person in his family to survive. And he came to the US and spent the rest of his life reflecting on his experience in the camps and human resilience, and what he identified that he felt was a primary resilience factor for people who lived through that experience was experiencing meaning. Okay. And so he identified different ways in which human beings experience meaning. A lot of that is informing what we're doing here. His book is very thin. It's called Man's Search for Meaning. The first half talks about his experience in the camps. The second half talks about logotherapy, which is a form of therapy identifying meaning that he developed as a result. Some people are really only interested in the first half. You guys might like the whole thing. I would read this on a sunny day, surrounded by people who love me. This can be a harrowing read at times, although deeply inspiring to me at the end. So one of the things he identified, one of the primary vehicles of human beings experiencing meaning is connection. That can be, for many of us, it's connecting to another human being. It could also be connecting to nature, connecting to culture, connecting to art. There's not just one way we do it. But again, it really highlights, if we have individuals who really only see their staff people all week long, what is the impact on them, not just in terms of their psychology, but in terms of their spiritual life as well. Transcendence, this is the experience, you could identify this word 1,000 ways, but I think of it as knowing that gut feeling that you are bigger than, you're connected to something bigger than just you. For many human beings, that can be community. That can be nature. One of the things, I make jokes, but I am truly at times homesick for the lake. I grew up close to it. And that was a frequent source for me to connect to that feeling of being part of the larger universe. We have farm fields, it's not the same. So, ask yourself, how often do these individuals get to go to a beautiful park or the lake if you're in Cleveland or whatever? How often do they get to experience that in nature? And then finally, meaning. And again, we could talk about meaning in lots of different ways. Frankel identifies it in some specific ways. But for this, let me just ask you guys a question. How important is it to you that your life is largely dedicated to helping other people? How important is your service to you?
Very,
It's incredibly important, right? It's probably really central. And we'll talk, we're going to sort of wrap up on this and pick up that thread when we come back to talk about self-care. But it is deeply, deeply meaningful to you. You guys are not doing what you do just to get a paycheck. God knows there are easier ways to make money, right? So now imagine if someone said to you, okay, Megan, we're going to take care of your every need forever. You won the lottery. You'll never have to worry about money ever again. You never have to have a job again. All your needs are cared for every day. But you're never going to feel helpful to another human being again. That would be a terrible loss, right? Terrible. And yet ask yourself, how often do the individuals we serve get to have that feeling of service? Very rarely. And so when we can identify whether it's connection, transcendence, meaning, when we can start to think about what does this person's spiritual life look like, maybe just in this context, maybe we don't have to talk about religious practice at all, but can we look for ways to augment this or encourage it where it already exists or bring it into the conversation? Then I think we really can be addressing people's spiritual health. Right. And obviously, if you are working with like an ordained person or a chaplain or whatever, that's great. And they've got expertise that you don't, and yay. But we can really, I think, address this in ways that as mental health folks, I think sometimes we're a little wary of. And I don't think we have to be. I think we can be respectful and have good, solid professional boundaries, but still address this really important component of what human beings are. So I am going to leave it there. We can absolutely pause for some questions, and then I want to give us a decent sized break, let you guys walk around and do stuff, and then we'll come back and finish up with some self-care stuff. But any thoughts or questions or observations that any of this has brought up for you guys?
well, I was gonna say, Laura, when you were talking about the medical piece,
Mhm.
that's so big for a lot of our people.
Yeah.
And the requirement now for our behavior team,
Mhm.
Megan and Brina can speak to this because they sit on that team as well, is making sure that we have that medical clearance, if you will, before we get started.
Great. Great.
On
Yeah.
the behavior team, and I know that's not always an easy thing.
Mhm.
Sometimes the guardians are like, oh, what do you need? Everything's fine. What do you need to know about?
Mhm.
But really
Yeah.
try to get, something from their last primary care visit or something that's showing that they're medically stable.
Yes, absolutely. And I think you're intuitive. I would imagine that you're kind of putting these two things together, but I would also make sure dental health is being addressed, which for some folks, especially like if they have sensory sensitivities, or this is interesting. Some people, especially people on the autism spectrum, but it can show up other places. If they have proprioceptive issues, they may not like going backwards in a dentist chair. And so it's not uncommon for their dental health to be neglected. And we know that infections from gum disease can really mess you up. So what you're talking about is so important, and I'm super glad that you guys are doing that. And I would make sure that dental stuff is also being addressed. This is also tricky, but if someone's avoidant of the dentist, you might need to work with that a little bit. Finding a dentist who can, not incline them back or work with them on doing that super slowly and acclimating. A little Xanax before the appointment might be a good idea, like whatever you need to do. But make sure that's being addressed as well. But yeah, that's so important that you guys are doing that. I love hearing that.
Yeah, and I think the spirituality piece,
Mhm.
in the past, I always felt like, most agencies don't want you to really talk in regards to spirituality with clients, it's in some policies basically. But I think as time has evolved, and even looking at Erickson's hierarchy of needs, spirituality goes over self-actualization.
Yep. Yep.
But what surprised me the most is that spirituality I see in older clients as they age more so than I do hear younger adults talking about the spiritual aspect of it.
Mhm.
I was talking to Megan with one individual in particular, doesn't have any, he wants more clarity about religion or God himself. And so I thought that was challenging. I was like, wow, would you even touch that?
And I think, yeah, I love hearing that. And as you know, Michael, I mean, Jung talked about that, right? That the first, that's where midlife crisis comes from. The idea that we spend roughly the first half of our life building our external world, mate acquisition, blah, blah, blah. And the second half, if things are going reasonably well, we turn inward or outward, if you like. And so again, that's a very developmentally appropriate thing. And I would say this, that we're so freaked out that I think the temptation is, oh, I don't know, let me get a priest in here. We're not talking about an exorcism, right? Like, it's okay to say, I don't know what God is. What do you think God is? Not like, come on, we're going to church. Nobody here is talking about proselytizing. Nobody here is talking about being inappropriately intrusive, but we're so freaked out. And, talk about like, it's easier to get forgiveness than permission. I'd rather just have the conversations. And if a family member is like, well, then I'd want to bring them in and talk about it. Like, here's what we're doing, or do you want to be a part of this conversation, or blah, 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 that it's not about right or wrong. It's not about imposing my view. It's simply about nurturing this part of a human. So I love hearing that, Michael. And if you guys figure out what God is, please let me know. I'd love to hear his thoughts. Yeah, great. I don't want to seem like I'm rushing through this. We could talk about this all day, but any other comments or questions? And of course, we'll have time during the second half as well for any of that. No, we're all good. Okay. So we're going to one. I'd like to take a little bit of a longer break because I know this first segment was kind of long. So let's come back at a quarter till. That gives us like I don't know, like a 12-minute break. Do be sure to like walk around and get water and stuff. And we will come back at 11:45. Okay, see you guys in a bit.